Hello class, in this video I will be talking about the motion component of our assessment. Okay, so the motion component, to begin with, as you will remember from my lectures, is basically the last one you do for the time being, for for the beginning, for term one purposes. After that you have your special tests and stuff like that, but for this portion we're just gonna keep it very simple, very basic. You've done your history, you've done your observation, you've done your palpation. So when it comes to the Hub-Nurse component that we talk about, the first three steps are done. Okay, H for history, O for observation, P for palpation. They're all done. So we are now on the motion section. Now we have a certain order for this, as you can see it on this one. So the correct order for movement assessment we would like to see is you start with a functional assessment of any joint you're doing, okay? And then active range of motion, which I will refer as AROM, and passive range of motion as PROM, and resisted range of motion for RROM. It's a common mistake that people also use RROM as restricted range of motion. That's not what the R is there for. It's more, it is for resisted range of motion. So that's the order we would like to see. We want to see, like, first two portions of this functional assessment and AROM is client is doing it individually. You're not helping the client, you're not doing things together. You want to see what the client is capable of by themselves. Okay, so that's very important to determine. We don't like to do assessments on the client before we see what the client can do, because we don't know what the limitations are based on their basically psychological or physiological limitations. So we don't, functional assessment is done by the client and active range of motion is done by the client. And then passive range of motion is done by the therapist. So the client needs to relax as much as possible, let the limb go if it's capable, if it's possible. And then resistant range of motion is done basically together. It's a teamwork. You push and then the client resists, and then we determine the strength and integrity of the joint, basically muscles around it, the surrounding crossing. So that's basic, very simple put of the assessment procedure, why we want to do it this way. Functional assessments basically multi-plane, is in multiple angles, or basically still even a single angle. It's an endurance component. So we'd give the client a weight of a certain pound, 5, 10, 4, 3, whatever the determination is at the time, and we ask the client to lift that up to a number of times, repetition. And once they can able to do that, if they are able to do that, we decide how many times they can do it, whether it's painful or not. Then we determine if it's functional, functionally fair, functionally poor, or non-functional. We have the 4 grading system here to keep it relatively simple. I'll go through some of the examples with you in a minute. We try to do it bilaterally, especially on the unaffected side first, or the less affected side first. Sometimes both sides are affected, so we will try to keep it on unaffected side or less affected side first. And then we definitely want to do bilaterally. The reason I put if applicable, they might not have another limb per se. There are certain situations that they are not able to do it bilaterally. So we simply, I just wanted to put if applicable there just in case. Also, during your history form, during your interview, client will determine, hopefully you asked, client will determine with the most painful or restricted movement. They're going to tell you, I can't do this, or it's a little bit difficult to do that. So you determine what action that is, and you try to make that action the last one you can possibly do. The reason of this is because we don't want a lingering effect of that pain. If you do it at first, and then it's going to hurt for the time being, and anytime you do other basically motions, then unfortunately it might actually give you a false positive, saying that, well, it hurts on all the actions, even though only one action really causes the pain, or maybe two. Now, we try to keep it simple when we make a fake case, and I'll give you like a one problem of one joint at a time. But real life is not like that. Real life is you have a shoulder issue, well, a lot of motions will basically be hurting. That's why we try to say the most painful one to determine. If you have a biceps brachia problem, it's, if it's soon enough, if it was happened very recently, if it happened very recently, then flexion of the shoulder probably will be painful actively. But if they do extension of the shoulder actively as well, that will also be painful because you're stretching the tissue. Depends on the client. So real life is a different component. We're just going to keep it simple with one problem at a time for our class purposes. But in real life, of course, you're going to have to improvise based on the information in front of you. Another guideline is always ensure your own and patient safety. Yes, and we always determine the patient's safety is very, very important, and sometimes we end up forgetting our own our own safety. You definitely want to make sure that you're also safe in the environment. If the client is going to fall, and you need to ensure their safety, absolutely, but you shouldn't endanger your own safety for the sacrifice of that. And we definitely want to make sure everybody's safe as much as possible. So before you start the tests, assessments, make sure they can actually complete the test in a safer environment. The only reason they couldn't complete the test should be is because they can't individually, not because the environment doesn't let them. Okay? So if you're asking someone to walk forward, make sure there's enough space to walk them forward, or run backward or walk backward, whatever. Make sure there is enough space, and make sure you're accompanying them that they're actually capable of doing it. And it says always palpate the joint, like the assess joint if applicable. Sometimes you have to hold the joint in order to do some passive range of motion. So if applicable, if you can, please of course palpate the joint while you're doing it again. So but you've done the palpation. This component of palpation is considering while it's moving, do you feel anything? Do you feel any crepitus or anything, any tendon snapping back and forth or in that manner? So keep that in mind. Okay. So we mentioned this. You can pause the video and read this through, but we talked about this already. So in this portion, I talk about in class as well, if you remember. Basically, I'm talking about please choose the functional assessments that are based on the case, based on the client, what is presented in front of you. So don't just choose two random functional tests because they're easier to do by you or easier to mark by you, or because client can do them. The component of this, the reason we do this, to determine also what the client cannot do. So that would be the goal for us to say like, okay, that is our goal. We are gonna work on this so the client can do this from now on. Okay, so that's very, very important. So please choose relevant to functional tests. So this is one of those cases that basically this is where you chart it. So I'm gonna go to the charting section in a minute, and then we'll walk through this a little bit better. So I'm gonna move on from this for now. Okay, and then we have the active range of motion. So as I said, active range of motion is done actively, okay, by the client. You don't really do anything. You just ask the client to do an action. If the client doesn't know what you mean, you will have to show the client what action you're talking about. And then once they do it, you basically observe and report. As it says, like the control of the motion, the client's willingness to do it. If they're hesitant, if they're apprehensive, they don't want to do it because they just say like it hurts. Well, okay, those are all important charting mechanisms. That's basically what we're looking for. If a client cannot complete the action of that joint, that you need to be aware of the full range of motion or within normal limit component, then you can tell the client, okay, why can't you do it? Are there any pain? Is there, like, what is wrong? And the client will give you reasons like, well, it will hurt, that's why I stopped. Well, does it hurt right now? No, it doesn't hurt right now, but I know it's gonna hurt. So there could be a psychological barrier, as in the client is expecting pain, so they don't do it. Now, we call that pain-free range of motion, but we also need to understand where the pain starts. So you might have to tell the client, okay, can you like go up till where it hurts? And if it's not if client is not giving you consent, that's perfectly fine. We just mark it as it is and chart it as like expectation of pain at that point, and then you just mark it there. In our exams, we're just gonna simply say like, well, for the shoulder, for example, if the client is going 50% abduction, excuse me, and then it says the client says that, well, it hurts at that point, we'll just basically make it as simple. What I'm telling you is a real life expectation that can happen, the situation of apprehension. Other than that, it could be they try but they can't do it because it's just simply not strong enough. There's muscle tone loss, we call it atrophy. There's an abrupt stuff of the joint, which means there could be a bone on bone situation. There's some osteophytes or bone spurs, as we call them, that doesn't allow the client to move. There could be muscle impingements going on, like supraspinatus is notorious with that one. That they're trying to do it, they can't do it. So they just, point is, they're actively doing it at this point. You don't help them, you just give them directions. Okay, and many reasons of why, as I said. You can look at these in your own time by simply pausing the video, read through, and you also should have access to these PowerPoints at this point. So we're going to talk about how to chart them in a minute. So when it comes to passive range of motion, this is where you do the motions for the client on the client, okay? So client needs to be as relatively as possible as relaxed. So you're looking at a relaxed client like supine, lying on the table, or sitting on the table, like sitting on a chair, that you're basically taking the gravity out of the situation as much as possible. So you're moving the joint of the client without client's help as much as possible to see if the problem is musculature or non-contractile tissue like a ligament or fascia or whatever. So this is the differentiation component. You also get to see the capsular patterns, capsular restrictions. So keep that in mind for now. It's a little bit of an advanced conversation. But the point, the most important point of the passive range of motion is client needs to be relaxed. And the second most important is the end feel. That what you feel as the therapist at the end range of that particular motion. So if we are doing a flexion of the shoulder, okay, normally flexion of the shoulder should give you a tissue stretch, which means what you feel as a therapist when you are bringing the client all the way from 0 degrees of GH flexion to 180 degrees of GH flexion, which is the normal limit, 160, 180, or in that region. And then once you push even further, which we call it passive overpressure as POP, that's what you feel. Not the client, you as the therapist. That's what we call it end feel by the client, by the therapist, excuse me. So when you push, what do you feel? Is it an abrupt stop? Is like a leathery component, the end feel, or is it like a tissue stretch, as in tight? Or another option is client is telling you, no, stop, it's going to hurt. Now, what did you feel in that particular example? Either the client stopped you because the assumption of pain, or simply client was hurting, so told you to stop. What did you feel personally as a therapist? You didn't feel pain because the client felt the pain. Pain is subjective, you don't feel the pain. So in that particular case, we chart the end feel component is an abnormality because it's abnormal end feel. But in that particular sense, because you couldn't get to the end feel, you didn't really feel anything, we mark it as empty. So empty end feel instead of a tissue stretch or bone on bone or leathery or internal derangement, like there's like a meniscus issue, for example. Don't worry about it right now. But for that particular purpose, you just need to chart as whatever you're feeling or couldn't feel. So for some reason that's you couldn't feel the client apprehension or actual pain, you just need to chart as empty. So that's why in your exams we might tell you, while you're doing a passive range of motion, yeah, the client said it's too hurting, too painful, so you couldn't finish it. You can only do it 75%. So we want you to chart the passive range of motion as 75% and go to the abnormal end feel section and chart as empty if we said it's painful. But if we said it's too tight, you couldn't go, then we are looking for tissue stretch, abnormal end feel. Now this is the difference. I want, you might have to go back and forth in the video. Now I'm going to explain this one more time. Normally, GH flexion, for example, and feel is tissue stretch. But if assuming you went all the way to normal limit, within normal limit, all the way you went to 180 degrees of flexion, and at the end what you should feel is tissue stretch. But if you have a very tight muscle and you try to go to 180 degrees but you couldn't, you end up being on 150 degrees, let's say 75%, okay, 145, 150, whatever, you still feel tissue stretch, but you're not on the normal limit. So you still need to chart abnormal end feel, even though it's the same feeling. So you need to chart abnormal end feel tissue stretch for the passive range of motion of the GH flexion. Whichever, we have a section, so we'll go over that, we'll talk about it. So keep that in mind, please. There's gonna be examples I'll show you. It's gonna be way more, hopefully clearer. And we have the passive range of motion is always slightly greater than active moment. That's, it's a typical presentation. And we're moving on. So I explained the end feel. You can pause the video and see, read for yourself and see if it makes more sense. Hopefully, gonna spend a couple seconds here so you can stop and read this through. So this is a good example, for example, like normal and abnormal end feels. Okay, so normal end feel for bone and bone elbow extension, lock your elbow, boom, it just locks. There's no tissue stretch there, it just goes boom and locks. For knee flexion, when you actually flex your knee, your calf muscle touch your hamstrings. So there we are. It's called soft tissue approximation. Same with the horizontal adduction of the GH. Your biceps can touch your breast tissue, for example. That's called soft tissue approximation. And an ankle dorsiflexion or a lot of other joints and feel is you're gonna come across. You're gonna see tissue stretch. So that's a normal end feel, and these are the abnormal end feel. I'm not gonna go over one by one right now. It's a lot of different pathologies here. I'm just gonna wait here for a second. You can pause the video and just take a quick look. Now we have the resistant range of motion. This is the last component. So we have the functional assessment, active range of motion, passive range of motion, and resistant range of motion is the last in the examination. This is a together one, as I said. It's a teamwork. Client is resisting your pressure as the therapist pressure. You have to make sure, though, this is the most important portion of this resistance component. Whatever joint you're testing, you have to put that joint into the open pack position of that joint. Whether it's shoulder, whether it's elbow, whether it's wrist, it has to be on the open pack position. Otherwise, it's not resistant range of motion. That then you're looking at a manual muscle testing of a particular muscle. So the reason I'm very particular and picky about it is because I'm trying to differentiate between resistant range of motion and manual muscle testing. Okay, so that's important. So at the neutral position is also called open pack position, is also called resting position. So keep that in mind. They're all the same thing. Okay. Another component that I would like to talk about right here is it says don't let me move you. So this is what the therapist tells the client. So which means client is controlling the tissue, controlling the test. You cannot get the client to do whatever they want at this point. There are good chances that client might be stronger than you in several cases. So in class I already mentioned this. Please make sure that do not let the client just go as hard as you can. Don't get competitive. This is not a competition. It's not a match. It's not a race. It's nothing to do with that. You're just testing the integrity of the joint together. Okay, so put the client and the joint in the resting position, also called open position, also called neutral position. I would like to repeat it because you might see it in different references in different books. And tell the client, okay, hold your joint here, hold your arm here, and do not let me move you. I'm going to push from this direction. I'm going to push from that direction. You have to communicate with the client and tell them where you're going to be pushing from. This isn't about reaction time. This isn't about surprising the client. That's a whole different test. This is basically checking the integrity of the joint. So you need to tell the client which direction you're going to be pushing from, and you have to tell the client, don't let me move you. And once they understand where you're going to be pushing from, and you start slowly loading in and then really give it a good go, because you're really testing the integrity of it, so you have to actually give a good pressure, then you start counting from 5 to 0 second wise. Okay, so 5, 4, 3, 2, 1. They have to hold on until 0. That's but basically how long you're supposed to be pushing. And once you start doing the countdown, client also knows that you're going to start at 5 and stop at 0. Now this is the grading system. So because when I go through the examinations examples of the chartings, I don't want to go through back and forth on this. So if you need to come back to this page right here in the video and then look at it again, or have your notes in front of you. So grading system is very simple. Now coincidentally, you count from 5 to 0 and grading is from 5 to 0, but it has really nothing to do with that. It's more of a judgment call when it comes to 5 to 0. You just have to hold it for 5 seconds. Don't assume that if they stop at 2, like when you say 5, 4, 3, 2, and then when you say 2 and then they collapse, they just let the arm go, they're like, I can't do it anymore. That doesn't mean the grading is 2. Okay, I'm gonna repeat, that does not mean the grading is 2, because read the 2, complete range of motion with gravity eliminated. So they can do the motion without gravity. So really supported joint, they can move it as long as you're supporting the joint to a degree. That doesn't mean that what just happened doesn't translate into grading 2. Okay, so you shouldn't just grade it by the seconds. So it's just a coincidence that grading versus the timing is both 5 to 0. So let's read this 5 plus. It's normal, complete range of motion against gravity with maximal resistance, which means it's your resistance. The client is resisting therapist resistance. So you need to give it a good push to get a good 5. Complete range of motion against gravity with moderate resistance. So they start shaking when you're pushing. They can hold on, but it's not necessarily the best. They're really struggling to a degree. So you can subjectively chart that as 4 or 3 plus, because then you look at the 3 plus, complete range of motion against gravity with minimal resistance. So between moderate and minimal, there is of course a subjective difference. How much really putting pressure the client is, how much struggling. That's where you start charting as 4 or 3 plus. Now the difference is, if the client can do the actions by themselves, which means AROM, then you immediately go for 3 anyway. They can do it. So charting mechanism needs to be properly executed grading mechanism needs to be properly charted based on your experience. So if the client can do AROM, you're automatically looking at 3 anyway, as in full range of motion. But if they cannot do full range of motion, okay, so that means clearly when it comes to resistant range of motion, that you're looking at some but not complete range of motion against gravity. So that automatically, you can't even do the open pack position particularly, because they're not able to do the complete range of motion. So it's all about assumptions. So when it comes to our examinations, we won't make that very complicated. While the client is doing the action, we'll simply let you decide, and we'll say, well, it was painful or not painful, and then the rest is basically up to you. Okay, we might tell you like, well, it's a little bit shaky, whatever, which means I'm just giving you a cue that don't put 5 because it was resistance was moderate. Otherwise, it's all subjective. So please go through this, okay? Especially the last, like second half of this grading system has a lot of pathologies going on. So we're not gonna go through those in the early phases of the program, but the more you learn about pathologies, the more you're gonna realize that there are a lot of possibilities of when it comes to resting range of motion. So keep that in mind, please. There's your possibilities. There come with lots of different reasons, so that's why we don't like to just talk about it in the first half of the program, because it can be very overwhelming. So keep the upper half for now relevant to your course, and then the second half will be a lot more relevant in the future. Okay? All right. So these are examples of it. I'll talk about examples in actual cases. So let's go over that. All right. So in front of us we have our first example, okay, for our assessment. So as we talked about on our previous video about the initial scan exam, so I'm going to move on from here and go to the AROM, PROM, ROM, and functional assessment portion. So we have a functional assessment right here as an example, okay, for this particular person. So chief complaint is right here, okay, and so because it's on the anterior shoulder, the ideal assessment techniques, functional assessments for this would be a flexion and an extension functional assessment. That's why we put here. Now W here represents the weighted, okay, which means that we need to use a dumbbell for here. As in class I will provide you a 5-pound dumbbell. You are basically asking the client to do the flexion exercises, okay, action up to 90 degrees 6 times, okay, 5 to 6 times. That will signify if they can do it up to 5 times to 6 times, then they're looking, you need to be charting as it's functional, okay, and that is basically the grading right here. It goes, and F stands for functional. Now why is there a dash here? Because we immediately at the beginning signified that it needs to be bilateral, correct? So in this case we have right and left. Now unaffected side first. So in this case you could write left and right to specify. It doesn't really matter as long as you do the test left first and then right after. That is all good. Charting doesn't have to be matching on that front. What needs to be matching is if you put right here, then the first one has to be right, and pain for also first one needs to be right. So I'm looking at this determination to find out what's on the next level. So if this was L first, as in left, then this first one would be left, and this first one would be left as well for pain. So Y obviously stands for yes, and if I didn't have any pain, or the client per se didn't have any pain, then I would put N as in no. So extension is right here, and then we have the flexion. So again, don't forget, therapist name goes here, patient name goes here, and date is extremely important, and date includes and has to include the year, okay? And then we're moving on. Now we have the palpation right here, as I talked in the previous video, and then we have the AROM and PROM right here. Now it's a good practice, as I said, to circle the R or L, whatever is the affected side, circle the affected side so you have a reminder all the time, and also circle the most painful one. So that's also a good indication to find out, like if you forget about it, it's a good indication to remember. Now as I said, for the PROM, okay, you need to, so you start with an AROM, and AROM is for S, okay, for S. Now so once we put for the S symbol is the reason I say S to make you remember, otherwise it's like a wiggly line. That's what for motion, okay, so just actively motion, actively done by the client. So we put the wiggly line right above the max if the client is doing a max. So for the left side, as you can see, he has no problem, he's doing it all the way to the max. And for the passive range of motion, we need to use the term the symbol I. So that's like a single line, and that signifies for passive range of motion. So you see the joint that I put here, GH, glenohumeral, or you could put shoulder in this example, but that needs to be there, because if you don't put it, then I don't know which joint that you're talking about, okay? And it already has its name here: flexion, extension, internal rotation, external rotation, abduction, adduction. The other letters also signifying for axial joints, which are cervical, thoracic, and lumbar. Then you can use left rotation, right side bending, and left side bending. But you will hear me say lateral flexion for this more medical terminology, but they put LSB as in left side bending or right side bending. So whatever is necessary, you can just basically use that. If you don't put the joint though, I don't know which one you're using. Okay, it would be a good practice to put a single line over the one that you're not using. So that way, whatever's left, that it's basically very straightforward. So we have abduction, adduction, internal rotation, external rotation, extension, and flexion. Now, technically, this adduction, as in we mentioned in class, is horizontal adduction. So doesn't necessarily require a full correction, but it would have been nice if the example was here saying horizontal adduction. Now, do you see a mistake or something missing? Yes, there's a active range of motion here is missing. That's what one of the mistakes that I would like to show once in a while, what not to do. So we definitely want to go through this. Now, what are the chances the therapist didn't ask the client to do active range of motion for horizontal adduction, but did it for passive range of motion? It's possible, but there's a good chance that they did it, but they simply forgot to chart. Sometimes it happens during the examination, you forget certain motions and you move on and then you remember later on. That's possible, but there's a good chance here in this case the therapist simply forgot to chart because they didn't forget to chart here. They simply did it right there. So I'm not sure what happened there, but from what I can tell, that's the point. I'm not sure what happened. When I look at the charting, if it's not clear what happened, and that there's a problem, because I'm not going to be there all the time, or the person who is looking at your charting is not going to be there while you're doing the assessment. So that's all I have to find out about the assessment and about the patient. Now, what is this wiggle, the zigzag? Okay, so right side affected extension is the most painful, so which means that I should be doing this one last. Okay, unaffected side left, affected side right, and then the most painful extension. So that's my basically protocol. On that front, when I look at all the ranges, they seem to be pretty good on most fronts. Now this signifies pain, which means that the first half of the flexion, the client was in pain to a degree. They were able to complete it, so it was painful for a while and then it stopped being painful. That's what it basically signifies. If it's a zigzag going on a halfway, that means that again, first half of the motion was painful, they were able to continue and finished the motion, and now we have a full range of motion, no problem. Now you could signify on the general observation or write it down right here that is it AROM or PROM painful. That would be another nice thing to specify, because at this point I'm understanding that both AROM and PROM are basically painful. You could just say AROM painful 50% right here underneath to signify, but doesn't matter right now. It's not a big deal. It's not a huge confusion. You could basically clarify it right here, but otherwise I'm just going to take that both AROM and PROM were painful at 50%. Okay, and we're looking at the extension one right now. For the extension, you're looking at quite a bit of more range of motion is painful the whole time basically, and they were able to do up till 75% roughly. That's what we're going to be using in our exams. 25%, 50%, 75%, like the common ones. I'm not going to make it weird and make like random numbers. It will be those quarters. So the person was able to do 75% AROM and it was painful the whole time and they didn't want to continue afterwards. So that's what it signifies. So let's just zoom in a little bit to get a better idea. Okay, right here. So there's a little bit of a gap here that I'm trying to show you. So when passively done, we were able to do it no problem. Actively when they did it, there was pain. So this is important detail to tell you here. So actively there was painful, passively there was not painful at this point because they were able to do it passively fully versus actively 75%. Okay. Now on the other hand, we have basically we are looking at resistant range of motion. So after our marking charting is done here, we move to resistant range of motion. So when it comes to resistant range of motion, let's go a little bit closer. Now I wrote down flexion, extension, external rotation, internal rotation, abduction, and adduction. It's not horizontal adduction here because this needs to be done on the open pack position, okay? So at this point it's adduction, not a horizontal adduction. Arm has to stay in the open pack position the whole time. There is no manipulation. Please remember that. The whole time I kept the GH in the open pack position. Now I put a star on this corner. It's not a has to. It's a reminder for me to say that, well, that is the most painful one. I did that last. You can actually write extension at the end of the whole thing instead of adduction. So I could have written external rotation, internal rotation, the first two, abduction, adduction 3 and 4, flexion and extension 5 and 6. So the sixth one would be extension. That would tell me that it's painful. Or sorry, it's the most painful action. That's why I kept it at the end. But for me, there are different variations. People chart, so I put a star here to remind myself that that's the most painful. Now, what does 5 signify? Again, you have to refer to your grading system, which means that on a maximal resistance, the client were able to hold on, no problem, okay? And there was no pain. That's the signification here, no pain. And when I put an arrow right here, that basically tells me the whole thing is no pain. That is a good shortcut you can do to tell me that all these lines are the same, so I don't have to write constantly no pain, no pain, no pain, no pain, no pain, no pain, no pain. You just put an arrow, 5, 5, 5, you put an arrow, and all good. So in this position, in this case, there's really no problem with the person, and I believe it was Michael Phelps, and he has no issue basically doing the resistant range of motion of the GH. He has problems with moving the arm actively on certain degrees. So that's like an interesting find out. So he has no problem with the strength of it, but he has feeling pain when he's doing it. But again, if you look at it, he doesn't have a problem really moving it to a full range when it comes to flexion, and he's almost done with the extension really. He just simply doesn't want to do it. It's just painful. I don't want to go for that, and that's fine. We just know that it's not too bad because other ranges are perfectly fine. However, in real life, yes, might be problem on external rotation, internal rotation, adduction, abduction. It might be painful the whole time. That's why you need to chart as it is. I'm just in this example keeping it relatively simple. Okay, so second example, let's go to make it hopefully more understandable. Now we are looking at Tom Cruise here apparently, and again we looked at the ISC in a previous video. Moving on right here. So when it comes to functional tests, we have basically, when you look at it, left elbow, okay, supination is the problem as we can see it. Now this is a great example of why we need to do relevant testing. So wall push is an example for elbow extension, and elbow flexion is an example for elbow flexion. That actually needs to be, so there's a lot of mistakes here, like I would like to show you. Okay, first of all, I made a mistake on the date. And how do you correct the date? By simply putting a single line through it and put your initials and the correct answer. So it's gonna be 2021 instead of 2020. In this case also, this needs to be weighted elbow flexion, so we have to put a W, just like on the GH example. I need to put a W there to signify that there was weighted elbow flexion, okay? And they had to do it 5 to 6 times. So when it comes to wall push, I also would like to differentiate right and left. So again, this should have been basically right and left, and it's done of course together at the same time as I showed you in class. But sometimes it's just right side is hurting or left side is hurting. How do I signify that? Like in this case, when I understand that it's functional, so they were able to do it 6 times, but it's also very painful. So I'm not sure if both sides were hurting or one side is hurting. So it's not really telling me a good story there. So this needs to be fixed. And in this one is, again, this needs to be fixed as in weighted elbow flexion. Now none of this matters because the problem is supination, which means that I need to know what what functional assessments that I need to be doing. There is an example, there is an assessment technique for supination and pronation. Those are the open door with palm down, open door with palm up, Now those two tests were supposed to be used. So this is a wrong choice of test. Is it relevant? Well, it is relevant to a degree, but hey, I should have used the proper, most relevant examples. Okay, but regardless, so this is what we have here. We talked about this already in the previous class, previous video, sorry. Same with here. So when it comes down to here, left affected, supination would be the last. So we are looking at here as the correction I made, because there's no option for pronation, supination, and technically they're external rotation, internal rotation in several books, but I don't like to use it, internal rotation, external rotation, for when you have the option to pronation, supination, because that's their true form, true name. So I put the joint here, elbow, and now there's supination and then pronation. So we did the right side first, and elbow only has 4 motions anyway for A-ROM, P-ROM. So there we are, okay? And we put all the A-ROM and P-ROM fully function, no problem, within normal limits, all good to go, perfect. And then when it comes to left, now when it comes to left, we have pronation and supination both at 75 degrees, and they're both painful. So when the person is doing pronation and supination of the elbow, they're feeling pain actively up till 75%. And they can only do 75% anyway. Passively, there's no problem. When you move the joint, they have no issues. Okay? That's basically what we have in front of us. Flexion and extension seems to be perfectly normal, so we're moving on. Okay? If you want to re-watch it, just basically re-watch it, trying to re-understand it if you're missing something. And moving to the wrist and range of motion. Now this is interesting because again, there's another mistake right here. Now, we have flexion, extension. Now I put a abbreviation. This is perfectly fine. You could have put flex and then EXT for extension, okay? Pron and sup. You don't have to write down entirely. That's why it's messy here. There's no flexion, and then I put extension, and then put pronation and put supination. It's handwriting, so of course it's not going to be the perfect timing, perfect way of writing it, but it still has to look a little bit better. We have the joint right here, just like we put joint right here, and then you have your grading system right here, so no pain anywhere, and then I put the arrow just like I mentioned before. Now the problem is, when it comes to elbow, resistant range of motion has actually 6 motions, which means wrist flexion and wrist extension is missing here. That's a big mistake, because most of the elbow joint muscles that cross through elbow and goes through the wrist, they do wrist flexion and extension. That's why we would like to test wrist flexion and extension on the resistant range of motion. So please keep that in mind, don't forget. So several mistakes in this when it comes to the assessment, okay? This is a good example of what not to do in basically in every step. So keep that in mind. So again, wrist flexion and wrist extension should be either the first one or then the middle, whatever, and then pronation and supination should have been done at the end. So in this case, I didn't technically do the most painful last because I skipped wrist flexion and extension. I didn't do the all tests, all motions. Now we got Harry Potter. Date is Valentine's Day 1995. Now moving to the Harry Potter case, what is the problem? Right flexion is the issue. Look at this. This is a complicated case. Look at him. I think he just came out from a war with Voldemort or something. Okay, this is right after the end of the last movie. Okay. So we got the initial scan exam, most painful, like the area of complaint. It's an achy all over. You can tell actually from the circles. Wrist flexion and wrist extension. Now, what are we missing here? What did I say in the previous one? What did I say that we should have put here? Because this is again weighted wrist flexion and weighted wrist extension. Right and left, everything is fine. There's pain on both right and left on wrist flexion. It's a complicated case, as I said. So I should have just simply put just another W, wrist flexion and wrist extension, to see that it is a weighted, because that's a problem. So please do that. And this should be at this point self-explanatory, but again, I crossed it, put sup, crossed it, put pron, and now here we have crossed it because it's a wrist case. Wrist has adduction and abduction technically, but they're called ulnar and radial deviation, as you know. So this is how you correct that very quickly. And if you can, as you can see, there's no pain, but there are limitations they simply don't want to do. So I'm not sure what's going on here. Is it because pain? Is it because tightness? So technically, if there's no pain, okay, and passive is basically is perfectly fine, this I take it that they're just tight all over the motions. So there's just a tight rest. They can't do pronation, they can't do supination, they can't do flexion, extension, radial, or they can't do fully. That they're just limited. They're obviously they're doing it, but they're not fully doing it. But when it comes to right wrist, it's a mess. Everything is painful. Everything is limited when it comes to A-ROM. P-ROM, however, perfectly fine. So this is how much of a complicated case it can be in several cases. This is a very realistic case on a wrist injury. They're able to do it, but it's painful, and also you are able to do it on behalf of them fully without any pain, without any problem. Now when it comes to this, flexion, extension, ulnar deviation, radial deviation, pronation, supination, that is a very correct way. It would have been nice to put a star here or something to make sure that this is the last motion is done as a reminder. And no pain again in any of those when you're actually doing it on the open pack position. And it's all four, which means they're able to resist a moderate resistance, not a maximal resistance. So there's a bit of a shaky concept going on. Okay, it's just they were like shaky when they were doing it. Okay, so keep this in mind, and let's move on to the next example. Severus Snape from 2018, June 30. It's my wedding anniversary. Okay, Severus Snape. Oh, that's actually my wedding date. All right, so I was treating Severus Snape on my wedding day apparently, and that's how dedicated I am. Now it's the neck issue, okay? So C-spine. Now we have the four corner superior and four corner inferior test, right and left, functional, functional, functional. So he's a very functional fella. Everything is fine. He can do it. It's just painful. Now during the functional assessment, when you start your exam and you check for any pain, and the person says yes, you definitely want to ask, can you continue? Okay, because otherwise, if you just immediately stop, oh my god, okay, if that hurts, please stop, that doesn't really signify the functionality of it, because we all process life with pain one day or another. Like, it's just normal. So you need to ask, can you continue? And it's a very normal case that people will say, yeah, I can continue, no problem, it's just sore. Then that's fine, they're functional, they're just sore, there's pain. Okay, so keep that in mind. I just love how I put a depressed stance here for general observation. It's very character, or accurate. Anyway, so for a C-spine, we are looking at left side bending, okay, is the most problem. So left lateral flexion is the most problem. And you can see I already crossed the right and left and the right section because we only have one neck. So you only need to do one portion here, not both sides, just one. Flexion, extension, right rotation, left rotation, right side bending or right lateral flexion, and then left side bending, left lateral flexion. Now, that's basically what we're looking at. And it's painful the whole time on right rotation, left rotation, right side bending, and left side bending. Now, I'm going to zoom in here to show you something, because we have a good example of abnormal Anfield right here, okay? So now look at the joint abnormal Anfield, what I put here. Right side bending and left side bending, tissue stretch, okay? So now look at this. Right side bending and left side bending, Anfield is tissue stretch. Why? Because we didn't quite reach at the end when it comes to passive range of motion. So it's not full. Why is that? It's because it's tissue stretch. At the end, it wasn't pain, it was simply tissue stretch. It was tight muscle. When they do it, it's painful up to a degree and then it stops. But when I do it on behalf of them, when I move their neck, then we are looking at tissue stretch. And same thing with rotation, I put tissue stretch as well. As you can see, it's not full either. So this is the exact example why I want you to use abnormal Anfield and how. Active, as in previous examples, there were limitations, especially in Harry Potter. But on passive, it was all full. So there was no abnormal end feel because I didn't feel anything abnormal. They weren't able to fully do it, but I was able to fully do it for them, their wrist. Now I'm not able to do fully right rotation, right side bending, left side bending. There's tissue stretch, there's tight neck, basically not allowing me to do. So that's why I chart abnormal end feel on cervical spine, right side bending, left side bending, and rotations, all tissue stretch. Okay, please keep that in mind. And when you look at the ranges, C-spine, flexion extension, right left side bending, right left rotation, all four. And basically where the neck stands in this neutral form between flexion and extension is open pec position. So you'll see it's very easy. This needs to be in supine ideally, and then all four and no pain. So realistic, somewhat. Could be pain in one of them, especially like flexion tends to be very painful, weak. Could be 3+, who knows. But again, that's what we're looking for. So that's our example, and we'll take a quick break, and I'll be back after the break. So on the other example, we have TOR. When we look at it here, everything looks good here. January 6, 2022. Again, lumbar and thoracic spine functional tests are the same, so you can see that anterior and posterior, but in this case we can see that it's non-functional, so they weren't able to reach for the knee or the foot, and it is painful on the anterior one, so when they reach forward, when they go for flexion. When they go for extension, no pain. Okay, so that's basically the example. So here is every time they do any action, basically, okay, they have pain. Okay, but I want to zoom in here because this is a good example of a complicated case. Okay, so now we have on flexion is the most painful one, as we noticed that we circled it. We have passive range of motion and resistant range of active range of motion and passive range of motion is painful at the end range. So no pain throughout the whole thing, but at the end it's painful, so they couldn't complete it. And it's all the same on right rotation, left rotation, right side bending, left side bending, except extension passive, it's fine. But when it comes down to active, when they do it, it is painful. Okay, that's why, because it's passive, is also painful. So they just didn't let me finish the motion towards to the normal limit. Then all empty except extension, because I was able to reach to the end field at the end for the extension. So that's how I chart empty end field, lumbar spine, all except extension. Okay, so it's a very complicated, painful scenario. However, when it comes to resistant range of motion, because he's in the center, there's no motion in the joint, we're just checking for muscle. This is an interesting case. He's all powerful, no problem. All 5+, whatever. Flexion, again, I put a star here. Okay, so there we are. 5, no pain, no pain, no pain. So he only feels pain when he's moving. You can actually confirm that from this one as well. Okay, so here we are. Okay, well, I hope it was helpful. If you have any more questions, just send me an email. It's more about practicing and just trying to see all the variations and what you can do with them. There's really it's really difficult to give you all the possible scenarios because everybody's very, very different. Everybody's reaction is very different. So I'll try to, I'm trying to show you the basic stuff, the foundation. After that, it's more of imagination and improvisation, really. So hopefully this was useful. But yeah, if you have any more questions, ask me in class or send me an email. All good. Okay. All right, guys. Have a good study.